Dr. Sahar Muhammad Kamal Mahmood. She is a professor of anesthesia, Faculty of Medicine, Ain Sham University at Egypt. She is MBBS, MD, MSc anesthesia. He has done fellowship in interventional pain management from Kolkata, Radhia Pain Clinic in 2011.
Good afternoon. This is my first topic in this great conference, and I'm very pleased to meet all these old friends and professors here. And my subject today is about chronic upper abdominal pain in adults. Our targets today, we will discuss definition, classifications, the pathophysiology, and the non-surgical treatment. The definitions of chronic upper abdominal pain, it's more than 3 bouts of pain affecting activities over a period of less than 3 months. It's classified as organic or functional, can be classified as visceral or somatic pain, constant or colicky. Organic classifications, we are suspecting organic pathology when we say that there is a red flags like weight loss, fever, vomiting, diarrhea, blood loss, jaundice. If the pain awake the patient at night, if the patient is more than 50 years old, if it is a constant pain, and such as chronic pancreatitis, cholecystitis, hepatoma, peritonitis, ulcerative colitis, and pyelonephritis. The other classification is functional pain. It's less likely to change with various locations, and it doesn't awaken the patient at night, and there is no evidence of disease. Can be affected by food intake, bowel movement, stress. Then there is a period of exacerbations and remission. May be associated with sacroiliitis, fibromyalgia, uveitis, migraine, as functional dyspepsia, irritable bowel syndrome, abdominal migraine, esophageal spasm, and chronic abdominal pain syndrome. This is our stages. The visceral pain, or maybe colicky, like irritable bowel syndrome, ureteric stone, chronic cholecystitis, intestinal obstruction, or somatic pain is constant, like parietal or capsular in origin, from liver congestion, carcinoma of the liver, or alcoholic hepatitis. This is all the classifications. The extra-abdominal causes of pain is like ischemic heart disease, herpes zoster, radiculopathy, sickle cell crisis, porphyria, hypercalcemia, and narcotic withdrawal. There is also a chronic abdominal wall pain resulted from post-operative hernia repair, surgical scar, implanted endometriosis, rectus sheath hematoma, thoracic radiculopathy or disc syndrome, anterocutaneous nerve entrapment syndrome, or due to myofascial pain syndrome as like fibromyalgia. Functional abdominal pain like irritable bowel syndrome, it is characterized by non-radiating, intermittent, and crampy, occurs after meal, and exacerbated by stress, and not interrupted by sleep. And when we want to diagnose it, it has to be according to Rome diagnostic criteria, that the pain relieved by bowel movement associated with change in the frequency of the stool and the consistency. Abdominal migraine, it is an episodic midline abdominal pain, can occur from 1 hour last to 72 hours, associated with nausea, vomiting, and vasomotor symptoms. Just it's a brief orientations, and it is also, there is a chronic abdominal pain syndrome. This is unrelated to meal or bowel movement, associated with pallor, nausea, headache, and it is constant and periumbilical. The other types is organic abdominal pain like chronic pancreatitis. It's a progressive inflammatory response affecting the morphology of the irreversible morphological changes in the pancreas and the pancreatic duct, cause diffuse pain, and it is related to fatty meal associated with steatorrhea, nausea, and vomiting. The other cause like pancreatic cancer, it is the diffuse and deeply seated colicky, increased on lying down and decreased by bending forward. And this pain is dynamic, changes its character. The second topic is what is the pathophysiology? The visceral pain may be caused by sympathetic overactivity. The nociceptors are located in the mucosa, muscles, or serosa. Stimuli may be stretch or ischemia, inflammation, thermal injury. The etiology of the cancer pain may be due to obstruction or infiltration to the autonomic plexus, somatic sensory infiltration, inflammatory association, or peritoneal seeding. The etiology of the functional abdominal pain, maybe it is caused due to visceral hyperalgesia. In brief, the treatment may be the dietary. We can avoid fatty meal and caffeine, like in the irritable bowel syndrome. Or pharmacologically, like peripherally, we can use altered GIT modality, secretions, intestinal flora by antispasmodic, prokinetics, antibiotics. We can use also Fentora, oxycodone, MST, or central to reduce the stress and the anxiety, like tricyclic antidepressant or SSRI or SNRI. Other associated therapies like psychotherapy, TENS, radiation therapy, acupuncture. But our interventional therapies, first by thoracic block, epidural block, celiac, splanchnic, neuroablations, radiofrequency, intrathecal opioids, neuromodulations, can use also for abdominal pain, intercostal nerve block, trigger point injection, tap block, or can use paravertebral or central ganglion neurolysis. And others are by intervention, dorsal root ganglia radiofrequency, cryoablation, quadratus lumborum block, somatic test simulation, and vagal nerve stimulation. Celiac plexus block indicated in acute and chronic pancreatitis, porphyria, sclerosing cholangitis, intra-abdominal malignancies, even inside intraoperative abdominal surgery. We know the causes of failure. Maybe it is due to distorted anatomy, post-radiation changes, surgery, concomitant somatic pain. If we do so, celiac without obliterating the somatic pain, or due to peritoneal seeding. The complications, most common diarrhea, orthostatic hypotension, the very severe is paraplegia or somatic neuritis, can cause disc perforation or aortic dissection, gastritis, or visceral injury. Techniques of the celiac: anterior approach through ultrasound or CT guided, posterior approach, retrocrural, transcrural, transaortic, transdiscal. There's endoscopic ultrasound guided. We use continuous plexus block or CT simulated fluoroscopy guided. Some questions are, can we combine celiac plexus with medications? Yes, it can lower pain score and with less drug use. Or we use medication first and then celiac plexus. Controlling the severe pain with medication, then performing the celiac plexus is more effective than combine those with each other. The time to do it early after the initial pain onset, even when the patient is responsive to anti-inflammatory drugs. Frequency: if it is for functional pain, we can do it apart by 2 weeks. If it is due to neuroablations, we can do 4 to 6 settings per year, aparted by 6 weeks. The diagnostic block is not warranted for terminal malignancies. Can the answer the questions? It is bilateral or unilateral single injection, Bilateral is more effective with longer pain relief and wider distribution of ethanol and more risky. Unilateral, it's not adequately exposed to the ganglia. In Korean Journal of Pain 2015, comparing bilateral retrocrural versus bilateral splanchnic nerve block for upper GIT tumor, resulted in efficacy of the splanchnic is clinically comparable to the plexus. And if we compare splanchnic neurolysis versus celiac plexus, splanchnic has better pain relief, less analgesia, consumption, and better quality of life. Can we combine celiac plexus with superior hypogastric? Effective if there is a combined abdominal pelvic pain. Can we do celiac plexus and paravertebral block if there is a lever capsular pain following hepatic radiofrequency ablation? Central ganglion neurolysis, it is done in 200 patients under endoscopic ultrasound as the rate of ganglion detections by the endoscopic ultrasound is 81%, and it leads to greater pain relief. But we couldn't do it through percutaneous approach. Can we do the celiac plexus with the diabetic gastroparesis? First, we do the epidural block at T7, paramedian, and then if the pain recur, we can do left celiac with 10 cc ethanol. Even in the pregnant patient with chronic pancreatitis, the most appropriate approach is transaortic to reduce the radiation. Celiac plexus with lever regenerations in red, it improves lever regeneration, increase the hepatic blood flow, and decrease the damage. In the polycystic kidney, we can do celiac plexus and intercostal nerve ablation. Even in critically ill patient, to increase the enteral feeding, to improve it, we can use also ultrasound-guided celiac plexus block. When they do the celiac plexus block, they found to treat upper abdominal pain, they found it helped in recurrent ischemic priapism, and it can help also in paralytic ileus. The ultrasound-guided percutaneous bilateral versus unilateral, we can use, there is no significant difference, even if the unilateral takes 20 ml and the bilateral takes 10 ml per side. Endoscopic, it is efficient, but the complications like total kidney infarction, splenic infarction should be considered. CT, the advantage of CT scan, to do celiac under CT scan, you can look at the tip of the needle, the depth of the needle, the angle of needle insertion, and the minimal distance they found on the right side, it can be 6 cm, and on the left side 6.8, with angles minimum between 227 and 35 on the right side.